Good evening, ladies and gentlemen. My name's John. I'm going to be your host this evening. Tonight, we're joined by acclaimed plastic surgeon Julene Samuels to discuss why pelvic floor muscles matter. Now, most of you probably know Dr. Samuels as a key opinion leader in the field of cosmetic and reconstructive surgery. After all, she's been published in a number of academic journals and provided her clinical expertise at a number of different conferences. She's also been an acclaimed teacher of various cosmetic surgical techniques. And you're probably asking yourself, why is Dr. Samuels talking about incontinence? Well, her motto is a woman's touch. And we would like her to discuss how, if you own a cosmetic practice, this might make sense to have this therapy in your office. Before I turn over to Dr. Samuels, what I'd like to do is give a couple of housekeeping rules. What we'll do is Dr. Samuels probably speak for about roughly half an hour. At the conclusion of a half an hour, we will open up the floor to questions. At any point in time throughout this presentation, you can go to that lower hand box where it says chat, type your questions in, and I'll review those with Dr. Samuels as soon as we start the Q&A. And we'll just go in the order in which received. And with that said, I'd like to turn this over to Dr. Samuels.
Thank you, John. So my background and specialty has been touched on a little bit here. I am a cosmetic plastic surgeon. I'm in solo private practice here in Louisville, Kentucky. My emphasis is on face, breast, as well as body. I do have a clinical faculty position at the University of Louisville, but I want to make really clear, everybody knows I'm a University of Kentucky grad. But I'm double board certified in general surgery and plastic surgery, and I did all of my surgical training at UT Southwestern, Parkland and Baylor in Dallas, Texas. So I have an all cash-based practice and have had that for 20 years. My surgical versus non-surgical ratio is approximately 60-40. And I think that is representative of most plastic surgeons, cosmetic surgeons especially, is that we see a large growth in the requests for non-surgical options to many problems. But where this all began for me really was when I introduced surgical labiaplasty into my cosmetic plastic surgery practice, and that was about 8 years ago. And just like facelifts and liposuction, you know, we offer non-surgical options, skincare, lasers, injectables. And so I feel like offering certainly vaginal rejuvenation and now some options that extend from the requests of my vaginal rejuvenation patients, my female wellness patients, I am now able to offer them something that is targeted specifically at the muscles and specifically for the urinary incontinence that accompanies much of their life changes. So I added non-surgical vaginal rejuvenation devices in 2014, and I now have several. I am a clinical investigator for some of those and have published actually an upcoming pretty comprehensive review article, which I think is going to be the first place that Emsella is mentioned. And in Dallas just last month, I was excited to be able to help BTL launch the high-fem technology in terms of two devices that incorporate that technology, Emsculpt for the abs and the buttock area, and Emsella. So we did that just last month in Dallas, and I would say it was the hot topic, and maybe some of you all were in attendance. But I think what's really been the reason for this excitement is that we never in the past have had a technology that targeted the muscles themselves, the pelvic floor muscles. So, you know, when you look at the prevalence of urinary incontinence, roughly by the age of 30% of patients are experiencing some form of urinary leakage, and that increases at the age of 40. It's about 40%, 50%. And by the time, especially a woman reaches menopause, urinary incontinence affects at least 50, half to 3/4 of women. It's definitely a significant contributor to decreased quality of life in those patients who experience urinary leakage. And when you look at alternative treatment options, such as pelvic floor muscle exercises like Kegels, physical therapy, electrostimulation, biofeedback, nerve stimulators, certain medications and Botox, those are of very limited efficacy, and many patients are just absolutely non-compliant with them because they don't work that well. Surgical remedies carry risk and morbidity. They don't always work, and sometimes there are residual symptoms. So we definitely have needed something that is non-surgical to help these patients. And when I started offering non-surgical therapies in my surgical practice, I realized there was a large segment of the population that didn't want surgery. That was sort of an epiphany moment for me. So when you look at the demographic and analyze that just a little bit, who does Emsella appeal to? We find that incontinence is one of the fastest growing categories of treatment in the market of feminine health. $900 annually is spent by patients for adult incontinence products like urinary pads. 12.8 billion adult incontinence products were sold globally in 2010. That increased to 18.5 billion products sold globally in 2015. And in 2020, it's estimated, 2020, that there will be 25.8 billion products sold just to treat and mask the symptoms of urinary incontinence. So what is Emsella? How does it work? EM, electromagnetic. Sella is the Latin word for chair, and it works on the principle of HIFEM, high intensity focused electromagnetic technology. It's patented by BTL. So the US FDA cleared indications are provided here. It provides entirely non-invasive electromagnetic stimulation of pelvic floor musculature for the purpose of rehab of weak pelvic floor muscles and restoration of neuromuscular control of that for the treatment of urinary incontinence in women. So as you know, the pelvic floor muscles are what supports the pelvic organs and provide continent control. And due to physiological changes with age, pregnancy, childbirth, and certainly menopause and advancing age, the pelvic floor muscles may become deconditioned and provide inadequate support for the pelvic organs and therefore loss of bladder control. So this leads to pelvic floor muscle dysfunction and a direct negative consequence upon urinary continence. So HIFEM, the mechanism of action, is that the electromagnetic field passes non-invasively through the pelvic floor area and the periurethral structures and interacts with the pelvic floor muscle motoneurons and triggers these supramaximal contractions of the pelvic floor muscles. And just in a little more detail, what's happening with these intense pelvic floor muscle contractions is that the induced tissue current, the electric current, depolarizes the motoneurons, causes concentric contractions, which are many times stronger than the maximal voluntary contraction. So independent of brain function, these muscle contractions can be held longer to stimulate the peripheral nerves of the pelvic floor. This induces a muscle fiber hyperplasia and hypertrophy, where we see the number and protein content of the muscle fibers increasing, and gradually increasing the intensity of the electromagnetic fields is very important in the re-education of the weak pelvic floor muscle patient, because the frequency of the pulses, the unique vigorousness of the contractions helps these patients who are really unable to perform high repetition and high rate pattern of contractions due to the pelvic floor muscle weakness. It's one of the reasons why Kegel exercises are of limited effectiveness. So we therefore restore neuromuscular control to the pelvic floor and to the pelvic floor muscles, which are tightened and lifted. So how does a typical treatment go? Who are the ideal candidates for HIFEM? And you can see here a patient fully clothed. The treatments begin at about 50% of the maximal intensity, and we gradually increase that over a minute or two. Doesn't take long to get the patient to 100%. The full treatment time is actually a very short 28 minutes, and there's no discomfort. It's a very relaxing treatment. And the patients that it's ideal for are patients with urinary incontinence of all varieties, all types of UI, in which there is negative impact on their activities of daily living and on their quality of life. And in essence, it's for patients who desire a non-surgical treatment method. They want something that's quick, something that's convenient, it's not painful, there's no recovery time needed, and they want to see a fairly quick onset of results. But I will emphasize that it's also for patients who will tolerate a multiple treatment package and who will be open to maintenance treatments. So the way a typical protocol proceeds is that we do a total of 6 treatments. We do 2 a week. Because patients do feel almost like as if they have had a workout of a muscle group. And so some of them report very mild, but will report some soreness. And we just think that twice a week is a sufficient number to achieve results without having any non-compliance. And it is indicated for, as I said earlier, all types of urinary incontinence. So stress urinary incontinence, urge incontinence, and mixed urinary incontinent patients. So Dr. Nathan Garrett and I pooled our data from a pilot study that we conducted for BTL in recent months. And we looked at 20 women, age range 45 to 77 years, with symptoms of stress, urge, and mixed urinary incontinence. And you see here a breakdown of the patients in our pilot study, which is the first of its kind here in the US. So we had 13 stress urinary incontinent patients, 4 with urge and 3 with mixed UI. All of our patients completed the full treatment course, which again is 6 treatments twice a week. They completed a King's Health questionnaire. They also reported frequency of urinary leakage episodes and pad usage. And we collected this data over a course of 6 months. 3 and 6 month follow-up was conducted, and then we statistically evaluated this. We presented this data for the first time again in Dallas at ASLMS. So the King's Health questionnaire is a very tested and proven method for assessing patients with urinary incontinence and other disorders, and basically is a patient self-administered self-report. It has 3 parts and consists of 21 items, so it's pretty thorough. Part 1 contains general health perception and incontinence impact on quality of life items. Part 2 contains questions directed at role limitations, physical limitations, social limitations, effect upon personal relationships and emotions, and disruption of sleep or energy cycles, severity measures taken by patients. Part 3 deals with more quantification of items related to frequency of leakage, nocturia, urgency, urge, stress, intercourse incontinence, nocturnal enuresis, infections, pain, and difficulty in voiding. And what we note with the use of the King's Health questionnaire is that lower scores indicate patient well-being, and high scores mean that the person's severely affected by their disease condition. So in our pilot study, with our stress urinary incontinent patients, we saw an improvement in activities of daily living and quality of life measures, things like sports, traveling, household tasks, and activities outside the home. With the urge incontinent patients, we saw a significant improvement in leakage, which interrupted the quality of sleep and traveling. And in the mixed urinary incontinent patient, we saw a combination of improvements in both ADL and quality of life measures. And the pilot study conclusion, therefore, was that there was a 60% overall improvement on the King's Health questionnaire, which was maintained at 6-month follow-up. 75% of subjects markedly decreased urinary leakage or were totally dry, and 31% of the patients decreased the use of their hygienic pads to a minimum, and 69% were totally eliminating their use. So the pilot study results definitely indicated to us that HiFem technology significantly improves the quality of life of these patients, and with all types of urinary incontinence. How do I incorporate Emsella into my practice? I have a cosmetic practice, and a large part of what I do is offer many items for female wellness, and my practice is 90% care of the female patient. So in my practice, Emsella is a perfect fit, and we use it as a standalone therapy for our patients to experience UI, or as an adjunctive treatment when we're doing some of our vaginal rejuvenation treatments, laser RF. I offer the O shot and surgical labiaplasty. So I think it's really easy for physicians who already have cosmetic services that they offer to incorporate this. You already have a built-in patient population that's ready for this offering, and your practices should be comfortable with cash paying patients. That seems to be a hurdle for practices that maybe are not cash based. But really, the sum total of this slide is, if you just let your patients know that you offer something like this, and then you finally have something that might end their urinary incontinence, they will ask you about it. And really, you just need to talk to your patients, listen to your patients, and they will respond by asking you questions very freely. So, as I said, 20 years ago, I stopped participating with any type of insurance reimbursement, and that was a happy day for me. I would rather see Emsella not fall into an insurance reimbursement category. I would rather see it remain a cash pay fee per procedure sort of option. And I will tell you, my staff really enjoy not having to chase down insurance payments, work on denials and appeal denials, and follow up on claims for reimbursement. And then even at the end of the day, you receive a insurance payment, and you've basically accepted a negotiated and discounted fee for those services. So I think that due to the very high prevalence of urinary incontinence in our patients over 50, that's a very large demographic. And given the fact that treatment alternatives are quite poor, the demand is very high for Emsella. And I think this creates a real value in any practice, not just a cosmetic practice. And when there is perceived value, patients will pay cash for that. And that's a fact. So what's a good business model for incorporating Emsella, and what kind of revenues are generated? What's the return of the investment that you make when you purchase one of these devices? And this is what we have settled on as a good level of pricing of the service, and patients have no qualms at all paying $300 per treatment. I know that in some parts of the country, Emsella providers are charging up to $500 per treatment. We actually offer the $1,800 6 treatment package at a discount when our patients are combining it with laser or RF device treatments for either the postpartum woman who's suffering from vaginal relaxation syndrome, or the postmenopausal patient who's suffering from genitourinary syndrome of menopause and its associated vulvovaginal atrophy. And when they are doing combination package treatments, we will offer them a discount of 20% or more on both package purchases. And that's been a very highly sought after combo, and very high patient satisfaction when they are combined together. And honestly, most of us who have laser and RF devices will find that some of our patients are refractory in total alleviation of their urinary incontinence. And so it's nice to be able to have something that doesn't target just the soft tissues, superficial soft tissues, submucosal tissues, but this targets the muscle and works very well in conjunction, or again, as a standalone device, depending on your initial evaluation of the patient's problem. So when I was able to offer Emsella, I was the first to market this in my territory, and I think you will be met with some, disbelievers, but when it starts to work, and patient word of mouth is a very powerful entity, it does offer you a unique opportunity to not just market to your local patients, but also to any referring physicians who you may have good relationships with, such as family practitioners, OBGYNs, urologists, internal medicine, and even maybe physical therapists who care about their patients who are refractory to their treatments. It's a little bit of a competitor to PT, but again, it works. So one of the first things we did was create a website devoted to female intimate wellness and included Emsella, linking it directly back to BTL for thoroughness of patient education. And we found that our younger patients were telling their mothers about it, and the older menopausal patients were sending their postpartum daughters to us, and it's sort of a viral thing. As far as that goes, with word of mouth referrals to us for this. And we are treating male patients. I serve on an advisory board for BTL where I get the opportunity to have conversation with urogynecologists and people who are largely have practices that deal with sexual medicine even. And we have a significant number of male patients that are referred to us by their female partners to help with things like post-prostatic urinary leakage or nocturnal leakage and enuresis. So I think that the demographic is broadening even after we introduced it to my practice. This is from my website, and you're welcome to visit it. We have chosen to put video in our website in appropriate places. And embedded in our website on the Emsella page, I have 2 videos where I discuss the technology, and then we have patient testimonial videos on there as well, and they're really popular, and I'm going to share one of those with you in just a minute. Other best practices tips, just like with anything new that you introduce in your practice, you have to tell your people about it. So we talk to our follow-up patients about things that are new in the practice when they're there for a follow-up for really anything, even something that would seemingly be unrelated. And when they hear about the chair, or I actually have it parked in my patient ed room and I'm in there discussing, I might be discussing a facelift with somebody, and they say, "What's that interesting chair in the corner with the blinking blue light?" And that's a perfect segue for me to tell them what's new in my practice. And when they express interest, this has been incredibly successful. We say, "Well, just have a seat. We'll just give you a partial or a full treatment." It's a pretty busy chair, so that would be chair schedule permitting. And we will do just a partial or a full treatment for them so that they can see what it feels like. It's not a full treatment by any means, and we tell them that, but that piques their interest, and many of them will go on to purchase a package, usually on the spot. We have done email blasts to our patients when we're announcing something new. I think local press releases are of some assistance if you have contacts within the media in your area. Social media, especially Facebook Live, when we're doing an event in the office or an open house, we'll have scheduled an hour where we might discuss a new technology or pan through the office with a couple different devices being featured. And it is amazing the number of people who will tune in to a Facebook Live event and ask you questions, and they just couldn't make your event. Things are archived that way, and they can visit them at their convenience. And you can offer, other educational events or seasonal promotions. And then you could consider, and we've done this, communications specific to referring physicians, the OBGYNs in my area, the urogynecologists, and that's helpful as well. And especially when you have a pilot study with some results, you can forward to them. So just some treatment pearls and some things to be aware of is, when you venture into this space of any non-surgical treatment for which there are surgical alternatives, you just need to be sure and remind the patient that the gold standard is still surgery, and that they might need to lower their expectations, and but yet give them the real data that these treatments can be very effective. And we hope that you're one of those. We manage our patient expectations that way, but I think you have to also tell patients that who may have more severe symptomatology, intrinsic sphincter disease deficiency, interstitial cystitis. You know, some conditions we may choose not to treat. Some patients may have symptoms that require more than 6 treatments. So what you're talking to them about is an average of 6 treatments to measurable results. And you need to emphasize that maintenance treatments will be necessary. At the present, we believe that 6 to 12 months are really probably, again, depending upon patient symptomatology, reasonable. We have some patients that will start to see results within their first 1 to 3 treatments, but most patients would say that the results come along a little more slowly. But I would not treat patients with partial packages, because by doing so, you're actually inviting evaluation of a partial result. And that's a philosophy we have with all of our non-surgical treatment options. You may want to discount additional packages if they buy more than one, or if they refer a patient to you for Emsella. And I track all of our patients with the same questionnaires and surveys we used in the pilot study, and provide interval follow-up after their last treatments so that we can retain them and offer them with a higher compliance, these maintenance treatments that we know they will need. So this is a patient's testimonial I want to share with you.
The feeling before was it consumed my life. You start looking, when you go places, where's the nearest bathroom? You want to be seated close to the bathroom. I would go maybe through, like I would get up and I wouldn't make it to the bathroom, so I'd have to change my pajamas. So I'd go through maybe sometimes, 2 or 3 a day. I would buy 2 pants that looked alike. So if I had an accident at work, I would just go to the bathroom and change into my second pair of pants, and nobody would ever know. I told them what I've been practicing just to make it through work to feel normal. And then you kind of go down that road, and then age kicks in, work kicks in. The mother stuff kicks in. You just forget about yourself and you take care of everything else around you. The next thing you know, you're starting to wear a pad. Then when you wear the pad or whatever, then you have hygiene problems. And so it consumed my life. To date, I'm very happy with the results that I've got from Emsella. It doesn't hurt. I don't know how you would describe that. It doesn't really hurt or feel good or anything. It's just there. It's wonderful. I don't know how it works, but it does. I don't have dribbles anymore. And when you're out in public, I can make it to the bathroom without dribbles. That's what you want to call it. And now, as a matter of fact, the only problem I have is I don't think about it. So sometimes I wait too long to think about it. And then I think, but I make it. I'm very happy on that part. The Emsella has changed my life for the better.
So, what I love about that, those are my patients, and of course I love them. They're as cute as they can be, but those are heartfelt responses. We hear that from all of our patients all the time. I don't know of anybody who's done Emsella so far in my treatment of them and not been pleased. So, and it is a life-changing experience for them. And I don't think I even realized until I opened this up to patients that they were really dealing with something that is truly for them horrible and impedes their activities of daily living. And to hear them finally tell us, gosh, I stopped thinking about it. It's just another wonderful thing we're able to offer them. And I think those sentiments are heartfelt, honest, and that's why I wanted to share them with you. But I'll end with this. This is one of my favorite marketing pieces that one of the marketing gurus at BTL came up with, John Ferris, who's our host tonight. And I love it because you see in the upper left-hand corner, the first stage is fear. What is this chair going to feel like? And what's the treatment going to feel like? And then number 2, amazement that it doesn't hurt and it's going to be tolerable. And number 3, acceptance. They sort of settle in and they read their book. And then finally, some patients do giggle and say it actually is enjoyable, but they're just typical sentiments. So I want to just go ahead and open this up for any questions that the audience may have. have. If you will send those to John, I'll be happy to answer the ones that I can.
Yeah, and Dr. Samuels, thank you very much, first of all. And we do have a few questions, but I also know there are some common questions that we hear quite often, and you actually touched on them a little bit in your presentation. One of those is combination therapy, and regardless if one offers RF or erbium or CO2 laser, there is a role, still with Emsella in the practice. And you kind of mentioned your pricing strategy there, but how do you or your staff bring it up when maybe the best thing is for that patient to do both, without looking like you're greedy for money or something like that, doing something in the patient's best interest?
Right. Well, I'll just role play a typical consult with you. The patients that come to us are usually aware that we offer laser or we offer RF. And so they are beginning a discussion by telling me, I have dryness, I have itching, I have painful sex. And my next question is, do you leak urine? So if they don't volunteer that information, I can guarantee that of the women who are approaching you, if you have those devices and they're approaching you for those devices, I will say probably at least 75% of those will be dealing with some sort of urinary leakage. And this is true for the postpartum women as well. We can't leave them out. Vaginal relaxation syndrome is alive and well. And women after pregnancy do also have trouble with urinary leakage where they may not have vaginal dryness, itching, or painful sex. They may have orgasmic dysfunction where the laxity leads to difficulty achieving an orgasm. But urinary leakage is sort of pandemic. So you may have to start out by asking patients until there is a broader awareness that there are treatments specifically for UI. And then once we settle upon, is it present or not, then I sort of try to get a gauge on what's the symptom severity so that I can decide, is this someone I want to offer combination therapy to? Do I want them to start with the chair, or do I want them to start with the vaginal devices and include the chair in that? And I think it just depends on the conversation you're having with your patients. But if you do feel like they are primarily concerned about urinary incontinence, they start with Emsella. If they are primarily concerned about genitourinary syndrome of menopause with urinary incontinence, we might start with the devices. And then I have some patients who are like, well, both of them sound good to me. What does it cost to do both? And if that is the case, they can even do some of their, they can do one of their Emsella treatments on the day that you do your RF or your laser treatment. So they're doing 2 Emsella treatments in a week, and they're only doing the device treatments 1 per month, times 3. So I think that kind of the answer to the question comes from just the kinds of the ways that they answer your questions as you have your initial consults with them. We have some patients that present initially and choose the device treatments only and wait to see if the urinary incontinence is sufficiently improved that they don't need to do anything else. And I'll tell you about probably about 25% to 1/3 of our vaginal device treatment patients will still have some urinary leakage. And what that tells me is that just neocollagenesis and neoelastogenesis near and around the urethral structures and the anterior vaginal wall, which is closest to the pelvic floor, is just not quite enough. And again, those treatments are not specifically directed to the muscle, which can be just pelvic floor relaxation and decreasing that angle of the bladder to the bladder outlet, and just lifting that pelvic floor plus their intravaginal treatments can be an excellent combination approach. And you may have to try one and switch to the other treatment arm, mid treatment. We have some patients that'll do 1 or 2 vaginal RF treatments and say, but I want to go ahead and do the chair. Can I add that in? Does that answer your question?
No, it's a perfect response. And I guess the one question that kind of comes out of that is there is a thought that it might be easier to place someone on the Emsella prior to undergoing a more, I wouldn't say invasive, but because you don't have to wear clothes. I mean, you wear your clothes with Emsella. Um, it's I can't think of the proper wording right now, but it's not as invasive as the laser or RF type device. So, do you find that usually you would start with Emsella? I know because you said you go. It depends on the condition, but does it make sense, to warm somebody up to the whole entire procedure, or do you think it's easier just going right with laser RF erbium to Emsella?
Well, that really depends on if they have significant vaginal complaints or not. If they're coming to me and they're talking about being dry and having painful sex, then I'm going to start them with an intravaginal device treatment. But if their primary complaint is urinary leakage, then yes, I would park them on the chair and start out with that. It just is more often that the complaints are conjunctive. They usually have urinary leakage when they have vaginal complaints. Not always, but and then the other thing that you sort of reiterated is it is so easy to just, as soon as somebody mentions the fact that urinary leakage is starting to really bother them, if you just give them a quick, even if it's just a 10 or 15-minute treatment, just so they can see what it feels like, that relieves that sense of intimidation that you refer to so well, that they go, $300 a treatment? Well, I can do this. We have many husbands of women who bring them to us, and they tell us, I'm hearing my wife complain about this, or she's wetting her pajamas at night. I mean, so they start to be very sympathetic, and are sometimes a source of support that makes the patient overcome the fears to come and ask us about it. And I'm seeing that with more and more frequency, that the husbands are finding out about this online, or they're going to provider lists and saying, hey, did you know, I had a patient just this week, her husband sent her and he said, did you know your doctor does this? And so I think that's not really probably even a product of corporate marketing. I mean, I think some of the patients that we're treating, their stories are getting out there, and it's a topic of conversation that we didn't even realize these patients were having.
That's a great response. And before we get to the audience's questions, one more question. You did discuss marketing, and you made the statement, if you let the people know, they're going to ask you all about it. And you gave the example of having the chair in the room and people ask. Are there other tactics in the waiting room or in the patient room that your staff uses to let the people know about the Emsella? We understand about the press releases, social media, e-blast, and other things that you mentioned, but is there anything you do maybe differently to help get the conversation started in the office, or is it through just your staff's conversations?
Well, I mean, I guess I didn't even think about this. I'm just lucky that I have an office manager who plants propaganda all over the office for everything we do. I don't think that I would ever hear patients say, I didn't know you offered this. You did my breast, but I didn't know you also did rhinoplasty. I mean, they don't get a chance to do that. If they squat in front of the toilet, they're looking at something on a wall. So that says Dr. Samuels must have for facial injection. So, I don't think it's too much. I think what I mean by that is, you BTL as a company, I'll just have to give you a plug here. I know you weren't expecting it, but the marketing support that you get with devices that you purchase is a big bullet point for me. Is the company going to be supportive in my attempts to disseminate the word on this? And so we have BTL brochures all over the office, Body by BTL, Ultra Femme 360, and Emsella. And so signage in the office is very important. It has to be tasteful. Obviously we're talking about feminine wellness and vaginal rejuvenation and urinary leakage. So it has to be tasteful, but and we don't leave patients sitting in the waiting room long enough to read a lot, but they see things and they'll come back and they'll ask us about it. So I think that visibility is very good. I have another software system in my office, and you can do the same thing with video loops that roll in your waiting rooms or even in your exam rooms. We have something called TouchMD, and patients will be able to access information along their areas of interest from our TouchMD screens, and they have portals created where they can access this from home. They can access it while they're waiting in an exam room. So I think there's multiple ways to let your audience know that you offer it, and having brochures and signage and anything you have in terms of video loops or patient consultation software can be customized to include this, so they're a little more educated when they speak with you.
Perfect. And then Iona has a few questions for you. And the first is, can the Emsella treatment be implemented in patients that had a mesh procedure for incontinence?
So there are some contraindications to the use of Emsella. It is electromagnetic, electrical current. So metal within the pelvic floor, hip replacements, things like that are contraindicated. Pacemakers. You could certainly mesh patients have been treated, and when we do our, that's not metal. Obviously, it's a implantable device, but it's not a strict contraindication. And I know some of our urogynecologists have treated patients who have been refractory to more complex pelvic floor reconstructions. I am not a urogynecologist, so I can't tell you how successful that is, but I know it can be done. But you just want to make sure that you're not including patients that have some very strict contraindications to electromagnetic field therapy.
Perfect. And then Iona also wants to know about the maintenance treatments. I know you kind of alluded to it a little bit, but she wants to know, are there maintenance treatments recommended and how often? And we'll I guess, ask for your opinion on this topic. I know there's different philosophies.
Right. So, again, just sort of referring back to the advisory board member conversations that we've had, most of us are seeing patients now that are at least 6 to 12 months out or longer. And what we're finding is that some patients, even at 12 months, are not requiring retreatment. Actually, one of those patients on the video testimonial that you saw has interstitial cystitis, and she also had rectal incontinence, fecal incontinence, and she had her 6 initial treatments, and she has not had any retreatments, and she's now getting close to being a year out. So I saw her in the office recently, and she actually does think she will need retreatment sometime in the next 3 to 6 months. But that's, she was one of our more symptomatic patients. I have some patients that feel like they need it again between 6 and 12 months, and some patients that we've treated 8 times rather than just the initial 6. So I would say I would be in those follow-ups that I mentioned, or questionnaires or surveys that we're sending our treated patients. I would be starting to ask them between 6 to 12 months, do you feel like you need retreatment? And some of those patients will say yes, some will go longer. So I'd say on average, just like with the laser and the RF, 12 months would be a reasonable retreatment interval to expect, if that's helpful.
Perfect. And then Darren has a question about IUDs, and I know you discussed metal, but he wants to know if you could treat patients that have IUDs. So if you just want to take that question quickly.
Right. I haven't had anybody present to me who had an IUD. So what would BTL tell us to tell those patients?
If there's no metal, they're
Right.
metal free.
Like a Marina IUD or something like that.
Yeah.
Yeah, I think you just have to err on the side of caution, but definitely ask the question. is it metal? I think the small amount of metal that it would be, most of them are going to be marine IUDs, I would think, and I think those would be fine. But
Okay.
but I would err on the side of caution.
And then Iona has another question following up to her maintenance treatment. She says that, I guess, when you get to your year out, do you think you're going to be doing one maintenance treatment or the package of 6 or some combination of? Do you know yet?
No, I mean, I don't think we'll need a full treatment package on the patients that I'm seeing. Most of my patients are going to have stress urinary incontinence and urge incontinence. So I don't do complex pelvic floor reconstruction where I would have patients with overactive bladder presenting to me or neurogenic bladder. Those patients may need a package a year. But for stress and urge incontinence, I'm probably going to offer them more of a 1 to 3 retreatment package. But if they are feeling restored after a single treatment, those would be the patients that I would consider selling individual treatments to, because they've experienced a full treatment package. They've experienced results. They're your happy patients already. They're not the ones that are evaluating this on a partial result. They've had a full treatment. So I think at that point it would be okay to do 1 to 3 treatment packages. It would be up to you, and I would certainly favor doing that with patients that I have a healthy relationship with, and an understanding that I'm not guaranteeing that they just need one maintenance treatment. But those are questions that we're still ferreting out as early users. So that's just my answer at this point.
Okay, that's perfect. And with that, I don't see any other open questions. I'll give the audience a moment if they'd like to ask any additional questions. Please do so at this time. Dr. Samuels is free for another 10 minutes to answer any other questions.
Thank you, John.
And
thanks for attending, everyone.
Okay, it looks like there are no additional questions coming in. So we would like to, first of all, thank everyone for spending their Tuesday evening with BTL and Dr. Samuels. And the other thing is we also want to thank Dr. Samuels for taking the time out of her busy schedule to also educate us. So thank you, Dr. Samuels, and thank you to all. We appreciate it.